Just next, just put these slides. Yeah, okay, next. Okay, next. Yeah, okay. Now I'm just showing you. I think maybe one more. One more. Yeah, stop here. See, now these are all on white light that you're looking. You're seeing some kind of focal lesions. Here, here, here. Okay, they're all looking focal, but when you interrogate them with NBI, you can make out that this is looking brown. So you say, okay, this looks like maybe gastric epithelium, ectopic epithelium hai. Yahan, this is not looking brown, this is looking white or something else. Here it's again looking a little brown. So what is it? Now here, remember, when you magnify and interrogate, this is an island of ectopic thing, whether you want to call it a Barrett or whatever you want to call it, or a inlet patch. Now this is something that is looking, you can make out the vessels very well. This is an angioectasia and the thing. Now this is looking brown. Here both looking fairly similar, but when you go to magnification and think, you can make out this is a squamous cell cancer. Okay. Why do you, Rakesh, now what's your name? Rajesh. Rajesh, why do you call this a squamous cell cancer? Why do you call it a squamous cell cancer here? Are you able to make out? Can we switch this off? I'll use this. No, let this be. They can switch it off there, that's all. Anyone? Very important is that you have this, what we call a demarcation line that is there, and it has become brown. So if you have a focal area of brown, right? Focal area of brown, you start suspecting that it may be a squamous cell cancer. Focal area of brown. But here when you look at it closely, you can make out different. Focal area of brown, and you see IPCLs. You say that possibly this is definitely high grade dysplasia or cancer. So it has to be focal. Remember that changes, whether it's in the stomach or in the esophagus, more importance is when it is focal. Suppose you have multiple red areas in the stomach, it's more likely to be erosions or some kind of inflammation rather than gastric cancer. If you have one lesion, they say, nahin, ek hi hai, may be suspicious. How often do you see one erosion? Not very often. Okay, next slide. Now this is something that you need to, maybe you can just take a picture of it, because this is the classification that is used, not what is in that room. That's the old classification. That's a little difficult to remember. Okay. So we have AB. A is and B. B we have three types. Okay. We'll go through each of these. A is without severe irregularity, and here is severe irregularity. The vessels look abnormal. And the micro vessels are either normal or mild irregularity, and that is a feature of normal or some inflammation or low grade neoplasia. On the other hand, if you have severe with a loop-like formation, without a loop-like formation, and highly dilated abnormal vessels, it tells you the depth. Okay, we'll go to just understand this as a concept. That because now it will be all on.
Regarding vessels only, no surface.
Surface nahi hai na. In esophagus is only IPCL. There is no surface. Next. Now, this is what you didn't see in the first patient, but in the second patient you are seeing something like this. Right? Now, as I said, normal, low density, not many things, but look like sperm heads. Okay. Now here they are little more in density, but they are still looking small and kind of looped. Now this is called type A. Type A is not sinister. Don't worry about it at all. Next slide. Now look here, now two things have happened here. You have now called, this is what the Japanese called an area formation. It has found a focal area. It's not kind of diffuse. It's found this focal brown area in which you find this. This is suspicious. This may be moderate, this place, yeah. And here it is much more, and now they have become a little elongated. Okay. Now they are looking more like what Shreya uses, hair clips. If you remember the hair clips, right? This is, if they are in a focal area, it is suspicious. This is type B1, loop. Can you see this like a hair clip? Okay? Next. Now you have B2, which is no longer looking like a hair clip. It is looking more like a, that other, what is the other clip that you call here? Shreya? दूसरा जो होता है बड़ा वाला? U. Not the tight clip, the other one. Okay? It starts looking like that. Again you can see the area formation, yeah? And then you find this is opened up. That clip is opened up now. And this is B2. So it's no longer looking like a loop, it's non-loop or open. B2, next. And this, just go back, this tells you that that is, go back, yeah, this is more advanced, it's gone a little deeper, right? It's no longer in the epithelium alone, it might have gone down, muscularis, mucosae, SM1. But yes, you can still try some ASD here. Next. Next. Oh, B3, okay, you come to B3, sorry. So here, what you find now, you start seeing these green fellows, your friends. You're asking me, Once you start seeing these big fellows, that means we have gone little lower down. We have gone deeper. And these are dilated vessels. You're not worried so much of IPCLs. Now these vessels are a little dilated. And that is telling me that those vessels, which are normally superficial, have now come to the surface to feed or drain the blood. Next slide. Okay. So, brown area with these chaps looking like clips, small clips or ants. Early, it becomes like an open clip, becomes a little more deeper, and once you see these dilated vessels is B3. B3, no question of endotherapy. B1, B2, endotherapy. Here be careful, sometimes you may find that it might have gone lower, you may have to change your strategy after the histology. This you can safely remove. So if you have a brownish area with this, so you have A1 which is normal or inflammation or low grade. So that patient you can watch or follow up or whatever. B1, go and resect. B2, send it to someone who can do a better ESD or be prepared for what it is. B3 is for CTRT, whatever. Keyboard. Yeah. What happens here, there is another concept which I didn't bring out, is something called avascular areas, AVN. So avascular area, AVA, once you have avascular areas, that tells us that the depth of invasion is deeper. So that is a bad sign. So when you have this, it's good for an endoscopist, whereas that is good for the oncosurgeon or radiation.
Basically, to understand the pathophysiology or natural history, if this progress to this, that
Correct.
means conceptually the vascularity will decrease or vessels become
The bigger vessels become seen.
so that gets focused in conceptually.
Next slide. Okay. So here the chance of you having any lymph node metastasis is virtually nil. Here you will may have lymph node metastasis. So this is a group that you will get the histology, maybe do an EUS, CT, whatever it is, and if the histology doesn't show much, you may follow up or send it for chemotherapy. But this patient, very high chance, so you will not even try any endotherapy. Okay, clear? So what do we have as squamous cell cancer? Would you recapitulate for me?
One is IPCL pattern, area of demarcation formation ground.
So on white light, you are going to look at it, see if there is anything abnormal. Kuch redness hai, is a little bumpy area, little irregularity, right? 2, once you finish white light, then you want to see on thing, is there a brown area, a well demarcated area or area formation. Then you focus and look at the kind of IPCLs and then predict the depth. You also want to find out the horizontal extent if you want to resect it. So that is what we will try and do if there is a patient. Any doubt? Now, I am sure you are doing mainly white light, but remember, in white light also we can recognize. Your decision taking may not be that easy, but you should be able to recognize. And if you learn NBI, you become masters at white light. That is the funny thing, is that you training like this will help you become better at white light endoscopy. So it's not that NBI nahi hai yaar chodo, nahi. You actually get better. Because now you're training your mind and your eyes to pick up very subtle things. Okay, come.
This classification different than that 1 to 10, V1 to V5 like
Yeah, this thing, Inouye's was a little complicated, then Inouye himself simplified it. And then the Japanese society then simplified, gets A virtually. Then you start getting this as B1, B2, B3. Basically, it has to be make it easier for non-experts to be able to. The moment you make it more classification, it's like what your hyperlipidemia classification. याद है? मुझे तो याद नहीं है. Classification of anti-arrhythmic drugs. Yes. I can't remember. It's because it's too complex. Want to do? Want to do? You do it? Come. Come.